طيب بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. Today will be the last lecture this year 2024. We'll stop and we'll wait after the exam, then we will resume inshallah this scientific, very important scientific platform. It is my pleasure today to introduce Dr. Amin Altigani to the resident of Sudan Clinical Oncology Board. Dr. Altigani is an expert with over 20 years in medical oncology. Currently, he works as a consultant and section head of medical oncology at Prince Mohammed bin Abdulaziz Hospital and the Ministry of National Guard in Al-Madinah Al-Munawwara, Saudi Arabia. Dr. Altigani has a distinguished set of qualifications, including membership of Royal College of Physicians of Ireland and the membership of Royal College of Physicians and Surgeons of Glasgow. And also he has a Saudi Board of Medical Oncology. Dr. Amin also has a specialty certificate in medical oncology from United Kingdom, and his effort extend beyond clinical practice as he is deeply involved in teaching and research with multiple publications contributing to oncology field. Today we will be lecturing on testicular cancer. We are very grateful for Dr. Amin Altigani willingness to share his experience under these difficult circumstances, the war conflict going now, considering the needs of our residents in Sudan. He showed commitment all of the time. He's asking about residents and oncology issues in Sudan. I am pleased to introduce him to you, and please join me to welcome Dr. Amin Altigani. And Dr. Amin Altigani, the floor is yours now. Welcome.
طيب في مجموعة تجون لكن let us start with أي سؤال ممكن توجهون حتى during my presentation. بسم الله الرحمن الرحيم والصلاة والسلام على رسول الله. So regarding the testicular cancer, if we speak about the incidence, actually it accounts about like 1% of all malignant disease in men. But it is the most common malignancy in men aging from 15 to 35 years of age. And as you can see here, on the right side of this, the incidence is gradually increasing. This is from 1970s or mid-1970s, and then in 2000, in both white population and black population, the incidence is going up. And this is actually the number per 100,000 person per year. So here we can see, for example, for the black, about 0.5 person, 0.5 per 100,000 per year. And for the white, it is more common, reach up to like 3 or maybe 4 per 100,000 per year. So the number is increasing gradually. So when we are speaking about the risk factor, regarding risk factor, actually having previous testicular cancer by itself is a risk factor. And it increases the risk by 4% to the contralateral side. Cryptorchidism, which is an undescended testis, it is also one of the important risk factors. Congenital inguinal hernia is also found to be one of the risk factors. Mumps-orchitis, and also patients with first-degree relatives who have the disease. So when we speak about the pathology, germ cell tumors in men, we are speaking about in men, but because we know that in women something different. We have seminoma, and we have the non-seminomas. And non-seminomas include embryonal carcinoma, choriocarcinoma, yolk sac tumor, which is called endodermal sinus tumor, and teratoma. And also we have spermatocytic seminoma. We have the sex core, gonadal stromal tumors, and this is like Leydig cell tumor, steroid cell tumor, and granulosa cell tumor. And also we have lymphoma, but this is not so common. Regarding the other classification, like classification in type, there is upper DSM tumor and classified, as I mentioned, non-seminoma versus seminoma. Seminoma is seminoma, non-seminoma either will be embryonal carcinoma, choriocarcinoma, yolk sac tumor, or teratoma. And we have also spermatocytic seminoma, not associated with germ cell neoplasia inside. And we have the pediatric, the children germ cell tumor. The important thing here is to see the differences between seminoma and non-seminoma. And we can see the majority of cases of the bulk are non-seminoma. It accounts about 60% of germ cell tumor in adult male compared to 40% for seminoma. Regarding the age for non-seminoma, 20 to 30 years. For seminoma, 30 to 40, it is a bit older. For seminoma, we know that it is a slowly progressive tumor, not like non-seminoma, which is rapidly progressive. Both of them are chemosensitive. Seminoma is radiosensitive, but for non-seminoma, usually radiation not useful. Sometimes you are using it, but generally speaking, it is not sensitive to radiotherapy. Seminoma, no surgery, but for non-seminoma, surgery is useful. And here I mean by surgery, most of those cases will go for correctomy, but I mean after we discover it is seminoma, so if we have distant metastasis, so surgical resection will be no option here, and mainly we will get it systemically or by radiotherapy. While in non-seminoma, especially if you have like a retroperitoneal lymph nodes, so surgery here will be useful and more helpful when we compare it with seminoma. Seminoma, usually they have a negative tumor markers, but non-seminoma can have a high tumor markers. And this is usually sometimes if you have the pathology result, and it showed for you that the pathologist tell you this is seminoma, and you have a high tumor markers, so you need to tell him that there must be like a component of non-seminomatous germ cell tumor, because in seminoma, that marker should be negative. Sometimes there is a slight increase of the beta HCG. But if you have alpha fetoprotein, so this is non-seminoma. Even the pathology told you this is seminoma, tell him no, there is some component of non-seminoma because the alpha fetoprotein is high. Seminoma had rare organ metastasis, and non-seminoma had common organ metastasis. When we are speaking about the tumor markers, and this is mainly for, as I mentioned, for non-seminomatous germ cell tumors, we have the alpha fetoprotein. And alpha fetoprotein most commonly coming from the yolk sac or teratocarcinoma. So before doing the surgery, if you have these markers are high, so you have some clues that what will be the pathology. And it have like a half-life 5 to 7 days of alpha fetoprotein. FSCE coming from embryonal or choriocarcinoma or syncytial trophoblasts. The half-life is only 1 to 2 days. Regarding the third tumor marker is LDH. And LDH usually it is like a non-specific because it can occur from anything else. And usually it is a marker of cell turnover. So LDH is one of the markers, but can be like sometimes like a false positive if it is high, maybe there is other factors contribute. These are the serum tumor markers categories. We have S1, S2, and S3, and it is good, intermediate, and poor accordingly. For alpha fetoprotein, if you found it less than 1,000 nanogram per ml, that means this is S1. For S2 is 1,000 to 10,000, and S3 more than 10,000. BHCE less than 5,000, this will be S1, which is international unit per liter. If it is from 5,000 to 50,000, this is S2. And if it is more than 50,000, so this is S3. Regarding the LDH, for S1 should be like less than 1.5 times upper limit of normal. For S2, 1.5 to 10, and for S3, more than 10. But actually, in practice, some physicians use a cutoff of 3 times upper limit of normal because of the frequently false positive LDH elevations. Isochromosome 12p, and this is the short arm of chromosome 12, which is joined. This is usually one of the important diagnostic one of the important diagnostic for the germ cell tumor, and actually it occurs like for in up to 90%, like up to 90% of cases they have isochromosome 12p, and this is detected by FISH testing or chromosomal analysis, and usually you can see here it will be the two short arms of the chromosome, which is I2p. Usually it is not like a routinely done, but you can ask for it. And this is usually held in cases when we don't know where is the primary. And this is coming like classic question, like for unknown primary. So isochromosome 12p is very important in the diagnosis of it helps in confirming the diagnosis in some cases. Okay, so we'll go for the presentation. Most of the cases presented with painless or painful testis mass, but maybe it will be like painless. Maybe they have gynecomastia and or gynecodynia, which is the pain in the breast. Some cases they have testicular atrophy. This is can occur. Also an infertility, maybe a presentation. Or the patient can present it with a metastatic disease, which is like back pain. And back pain usually indicates that there is a retroperitoneal lymphadenopathy. Abdominal mass in some cases. Supraclavicular adenopathy is also one of the presentation. Patient can present it with thromboembolic events or respiratory signs or symptoms if came with metastasis in the lung. So there is key concepts which we need to know about testicular cancer, which is peculiar to testicular cancer. Do not biopsy the testes. Why do not biopsy? What is the problem if we biopsy the testes? Usually this can cause dissemination of the disease or making like a tract, and this can disseminate the disease. So biopsy should not be taken, and patient should be diagnosed based on ultrasound, also if we presented with testicular mass, so ultrasound of the testes, and the tumor markers also will help here. So biopsy is contraindicated. It's not advised to do it. Do not remove the testes through the scrotum. This is very important because also can cause dissemination of the disease and also can alter the lymphatic drainage, because the lymphatic drainage from the testes will go refers to the retroperitoneal lymph nodes. But if you do the surgery through the scrotum, this is mine, disturb the lymphatics, and the disease can disseminate it to other parts, like other pelvic lymph nodes. And in this case, the case will be more advanced than before. So two important things: no biopsy, do not remove the scrotum, and the surgery, it is an inguinal approach. And this is the urology, they know that. Check serum tumor markers prior to orthoectomy. This is very important. First, it will help in the diagnosis. It will help in the diagnosis, number one. The other thing, it will show you give you idea about the extent of the disease. If it is very high tumor marker like S3, so this will give you idea, and it will help you after surgery for monitoring, because it will help in the staging after surgery, because we are doing the staging after surgery, not before surgery. And any test needs to be urgently done. So evaluation, physical examination is very important to examine both testes, not only the affected one, because sometimes bilateral, transscrotal ultrasound, serum tumor markers, and then inguinal orthoectomy, and then CT chest, abdomen, and pelvis is very important to rule out any metastatic disease. It is very important to consider sperm banking. Those young men, they need to be counseled. If they are married or non-married, they need to be counseled about the sperm banking, because the possibility of infertility will be high. I don't know, sperm banking, is it available in Sudan or no? I am not sure. Okay. Regarding stage, stage 1, which is limited to the testes, or scrotum and spermatic core. Stage 2, if there is metastasis, the general staging to the retroperitoneal lymph nodes only. And serum tumor markers can only be mildly elevated here in stage 2, especially non-seminoma. Stage 3, this is distant metastasis, including pelvic lymph nodes, retroperitoneal nodal metastasis, plus high elevated serum tumor markers, also classified as stage 3. And it is very important in testicular cancer, we did not have stage 4. This is very important, because some people, they are said this is metastatic disease, so they think this is stage 4, no stage 4. So regarding stage 1S, what is meaning of 1S? That TNM0, M0, and S1 to 3, if the serum tumor markers is high, regardless, S1, S2, or S3, based on post-operative. Actually, this staging after orthoidectomy, serum tumor markers nadir. And this is usually, it depends on the type of the serum tumor marker. And we need to wait actually weeks, generally like 4 to 5 weeks to wait, because it depends on the half-life of the serum tumor markers and other factors. For example, for alpha-fetoprotein, which is 5 to 7 days, and for beta-HCG, 1 to 2 days. Beta-HCG might be normalized in 1 or 2 weeks, but alpha-fetoproteins will continue sometimes to 4 or 5 weeks to come to the nadir. And after that, we need to wait after surgery for like a month before staging the disease. And here, stage 1S should be treated like the same like as stage 3. Because if you have S1 after like you did surgery and it is only confined to the testes, and then after 4 or 5 weeks, still the tumor markers high. This is mainly in non-seminoma. So that means there is some disease elsewhere and should be treated like stage 3. Stage 2, stage 2A, which is lymph nodes up to 2 centimeters, and it is no more than 5 centimeter node in the retroperitoneal lymph node. Stage 2B, lymph node 2 to 5 centimeter, or it is more than 5 positive lymph nodes by retroperitoneal lymph node dissection. And this will be pathological here. And it's stage 2C, lymph nodes mass more than 5 centimeter. And serum tumor markers level must be like 0 or 1. So this is for stage 2. Stage 3, we have A and B and C also. Stage 3A, metastasis to lung and or limited to non-retroperitoneal nodes. And S and serum tumor markers 0 or 1. This is for stage 3A. For stage 3B, at least 1 serum tumor markers, which is equal to or none more than 2. And metastasis limited to any lymph nodes or lung. If stage 3C, any serum tumor markers, maybe equals 3 and or here any one of them, if it is high, so we will consider it as a 3. So 3 here, which is S1, S2, S3. Metastatic to organ other than the lungs, like liver or brain, or mediastinal, then seminoma, the absolute tumor. Here we consider it high stage 3C. So regarding seminoma, for stage 1, if here we are speaking about the options of treatment and the relapse rate. So for stage 1 seminoma, the relapse risk is the rate up to 15%. And if there is high risk features, it reaches up to 40%. And high risk feature like tumors, larger tumors more than 4 centimeter mass, or retestis involvement, which also, this is the hazard ratio 1.7 for retestis involvement. For tumor, big tumor is 2. What are the treatment options for stage 1 seminoma? We have 3 options here: surveillance, radiotherapy, or chemotherapy. For the surveillance, the relapse is 15% relapse. Giving radiotherapy, it is only 3 to 4% relapse. And giving carboplatin, usually are giving it very under the curve 1 or 2 cycles. The relapse also similar to the radiotherapy, which is 3 to 4%. Somebody will ask why I will go for surveillance, which is 15% relapse. Although it is the preferred option, and prefer to go for surveillance more than giving the treatment. Because if the patient relapses, the cure rate is more than 99%. So it is a very high cure rate. So this makes the difference why not to go for treatment immediately, because when they relapse, for stage 1 seminoma, the cure rate reaches 99% after relapse. This is study, which is published in 2011 for the carboplatin versus radiotherapy for stage 1 seminoma. This is a mature result of relapse and comparable cancer rates. And the result here showed that actually about more than 1,400 patients were randomized finding a 3 to 5 ratio. Patient received the carboplatin 573 radiotherapy, more than 900. And the relapse-free rates at 5 years were 94.7% for carboplatin and 96% for the radiotherapy. There is one death as a result of seminoma in the radiotherapy arm, And this is generally about this paper. So, but this difference between like 94.7 and 94.7 for carboplatin and 96% for radiotherapy is not significant. Is not significant. And those who patients receiving at least 99% of the carboplatin dose at 5 years, those who receive it, 99% actually, the relapse-free rate reaches 96.1, which is compared to 92.6 for those who received lower doses. And there was a clear reduction in the rate of contralateral testicular cancer. But this is generally about why we are using radiotherapy and carboplatin. For stage 1 seminomas, surveillance is the preferred course. That is what I mentioned. Although surveillance gives me 15% relapse rate, and surveillance do CT abdomen, chest X-ray, and we will do exam each visit. Clinical exam for the other contralateral and abdominal examination. It should be done every 4 months in the first 2 years, and then every 6 months in the 3 years after that. And there is no benefit of doing scans after 5 months. For seminoma stage 2A, which is less than 2 centimeters, and B, more than 2 centimeters, but less than 5 centimeters, radiotherapy is the standard of care. For less than 3 centimeters, this is 25 grays double field, the state brain for the lymph nodes. If radiotherapy is contraindicated, so the other option is to give chemo, and here either to give EP times 3 or EP times 4. When to do that, this is generally if we are going to avoid the bleomycin lung toxicity, especially so. We prefer to give EP etoposide cisplatin 4 cycle instead of giving 3 cycle of bleomycin, etoposide, and cisplatin. And this is mainly for stage 2B, but we can give it also for stage 2A. For benign seminoma, stage 1, the relapse risk is more higher, 27 to 30%. And if there is vascular invasion, it reaches 48%. No vascular invasion, it is 15 to 20%. And the treatment options also surveillance for those without a high risk factor like vascular. If there is no vascular invasion, usually we prefer to do surveillance, and the surveillance to do 2 scans versus 5 scans. This is actually, it depends, this is actually means per year. For the other options, either surveillance or to give 2 cycles of regimen, especially for vascular invasion positive, and the relapse here will be reduced from initially 48% to 5% only. Retroperitoneal lymph node dissection is also one of the options, and reduce the relapse to 10%, and mainly in the lungs. And we know retroperitoneal lymph node dissection needs a skilled surgeon to do it. Even here in Saudi Arabia, we have only small number of surgeons doing the retroperitoneal lymph node dissection, because it is not an easy surgery, and it also can leave a big scar sometimes. And if relapse, either to give BEP or VIP with the resection after the resection. This is follow-up for non-seminoma germ cell tumors, doing markers, chest X-ray and CT abdomen in the first year, every 2 months, 1 to 2 months. Chest X-ray, we will do it every other visit, and the scans 3 to 9 months. And then we continue year 2, we will increase the interval, year 3, and up to year 5. And there is no benefit doing it after year 5. I mean the chest X-ray or the CT scan, but we can do the tumor markers once per year. Okay, non-seminoma stage 2A, which is less than 2 centimeters or more than or B more than 2 centimeters. If it's stage 2A and normal markers, the treatment, the standard is to do retroperitoneal lymph dissection. And if it came like stage 1, because sometimes we will find like lymph nodes in the scan, and after surgery, and the retroperitoneal lymph nodes came negative, so we will down stage it to stage 1, and here we will do surveillance without not giving anything after the surgery. If it tends to be really or pathological stage 2, so we will give 2 cycles of that, or also surveillance an option here for stage 2A non-seminoma. If it's stage 2B and or abnormal markers, we will give chemotherapy upfront. And if there is residual tumor, so to be resected. If markers very abnormal, treat as advanced disease, as if it is stage 3. So the prognosis, we are using this prognosis mainly for stage 3, the advanced stage, and we have good and intermediate for seminoma. In seminoma, we do not have a poor prognosis. We have good and intermediate. Non-seminoma, we have good, intermediate, and poor. And for seminoma, for the good, this is the markers, whatever is the markers, but for the good, there should be no non-pulmonary metastasis. If there is pulmonary metastasis, it would be good, but if non-pulmonary, like liver metastasis, so it will not be good prognosis, which account like 90%. And intermediate prognosis, non-pulmonary metastasis there, like liver more and pain. For non-seminoma, the things are a little different. For the good risk regarding the tumor markers, because there is no markers in seminoma. If it is S1 or S1, so this is most likely in the good category for all, and this is it should be no non-pulmonary metastasis, only if they have lung metastasis, so it will be good with S1 markers. Intermediate, if the markers are higher, alpha-fetoprotein, beta HCE, and LDH more than 1.5 to 10. I think here there is some mistake with regard to alpha or the beta HCE or the alpha-fetoprotein. Okay, and non-pulmonary metastasis. So these markers, this S2 will be intermediate, and for the poor risk non-seminoma should be S3 tumor markers or primary mediastinal germ cell tumor will be considered poor category, and non-pulmonary metastasis also present So what is the treatment? Here the treatment between both seminoma and non-seminoma is similar for that. Is when I'm speaking about good and intermediate for them, but there is no prognosis for seminoma. So good prognosis, we will give 3 cycles of the regimen or 4 cycles of EP. As I mentioned, if you want to avoid bleomycin. Bleomycin should be avoided in smokers, in those with abnormal liver function, those with pre-existing lung disease, so there's or older people. So usually above 40 or 50 years old, we try to avoid the bleomycin because the risk of toxicity is higher. And this study showed that at 40 years, event-free survival, 91% on bev versus 54% for EP, and at 4 years overall survival, 96% for PEP, 92% for EP, but the overall survival is not significant. This is a difference came mainly in the MH3 survival. It is a good option we are using if we are going to avoid the neomycin toxicity. For the intermediate and poor prognosis, here we need to give the 4 cycle of PEP. 3 will not be enough. And if we are not going to give 4 of them, so we will give BIP, which is seen that studied and seen it is equivalent to PEP. So PEP 4 is equal to BIP 4. So if we are not going to give neomycin BIP, prefer non-bio regimen if there is pulmonary metastasis and considering resection, especially if the patient going for resections and for the anesthesia, or also the risk of neomycin toxicity higher. Limited residual pulmonary capacity or oxygen operation. Okay. This is very important. Try to never dose reduce or dose delay for cows in testicular cancer. Be ridiculous. Give GCSF, give antibiotics. The patient receives the first cycle, and the second cycle, or whatever, and he present it to you with low counts. Do not delay his chemotherapy. Do not reduce his dose. It is not like other cancers. Give the full dose. But after the treatment, give GCSF, and even you can increase the dose of GCSF instead of giving 5 days, you can give more than that. Or double the dose. Instead of 300 microgram, give 600 microgram. But do not reduce the dose and do not delay. It is very important. Because maybe you have a case in your exam and one of the options of the treatment for 1 week or delay the or reduce the dose, so give the good dose. The chemotherapy, as I mentioned, then neomycin alongside cisplatin, EP, without neomycin, BIP here, we have etoposide, cisplatin, and we have ifosfamide, the ice or ifosfamide. And definitely we need to give this one. This is mainly for the third slide. For the second one, for germ cell tumors, we have BIP for cycles, including vinblastine, ifosfamide, cisplatin, for cycles, this is paclitaxel, ifosfamide, cisplatin, and also we have a high dose carbamazepine etoposide in the second line. Okay, so germ cell tumor chemotherapy for seminoma, we mentioned that carboplatin, 1 or 2 doses, but very important to give it AUC7, not less than that. If you give less than that, this is sub-therapeutic. So you need to give the full dose, regardless of anything. Stage 1 seminoma, either 1 bed or 2 cycles to bed. Pathological stage 2, this is after retroperitoneal lymph dissection, we give bed type 2 or EP type 2. Here there is no difference. Good risk disease, bed type 3 or EP type 4. It's actually summary of what I mentioned. Intermediate or poor risk disease, bed times 4 or VIP times 4. What are the salvage stage treatment? If the patient had relapsed after first line of therapy, we have the VEIP or cycles or the 4 cycle or a high dose chemotherapy with autologous stem cell transplant. This is also one of the options for the relapse cases. So I will go here briefly about cases, and if you can interact will be good. So case 1, this is stage 3 non-seminoma germ cell tumor on cycle 3 of 4. So we decided to give 4 cycles of them. And during cycle 3, the alpha fetoprotein had been dropping, but then again increased. So initially it was 5,000, then dropped to 50. Then after 50, it go again to 100 of the alpha fetoprotein. And when we do the imaging, it shows markedly smaller disease than at the baseline. So this is advanced stage 2. And treated. Definitely initially when he went like what to do now? And the reaction, if possible, will be better. Can anyone tell me what to do?
For me, go for circle.
Go for circle. Why to go for circle?
Partial response.
Now, the imaging showed smaller disease than the baseline. Here, the tumor markers start to increase. Although you see the very big drop from 5,000 to 50 and then again increase. So we will go for surgery. Other opinion? Let us go. So this is if the markers, markers should be declined and become negative. And if they rise during chemo, that means disease is progressing. And then to give treatment as if this is refractory disease that we need to give salvage. This salvage will be giving TIP, maybe TIP will be okay, or we can give VEIP, or some people can consider, because this is very bad, which is relapsing. So the marker should be declined, even if the scans show less disease. So this is one of the important, actually here, 3 and 4 rules of advance. So this is rule 1. Rule 1 is the markers increasing. That means this is relapsing or refractory, and we need to do salvage. Case 2. So this is the first rule of the 4. So we have 4 cases like this to complete the formula. So this 75-year-old man is advanced tumor. He completed 4 cycles of them for intermediate prognosis disease. So this is melanoma with retroperitoneal lymphadenopathy and pulmonary metastasis. Okay, so he completes the 4 cycles. So we repeat the scans, which reveals residual masses, but it is no more than 3 centimeters in size. Tumor markers are normal. What is the role of PET here, and what to do now? Anyone? Chapter 5, it's a normal 4 cycle of web. The scan shows residual mass, and this is what actually counting very frequent. Tumor markers normal, but the scan there is still residual, and it is not more than 3 centimeters, up to 3 centimeters. Is there any role for PET here? And what to do? I need another. Yes, Anna. What is that? I am not hearing you well.
Residual less than 3 centimeters, no additional intervention. PET scan, role of PET scan or follow-up?
صوت ما واضح. الرول اوف بيت سكان
follow-up.
يعني نعمل بيت سكان.
The role of BET is to show whether it is there is uptake. That means it is active tumor, or it is necrotic. If it is necrotic, just necrosis, that means there is no uptake, not for surgery.
Okay. But what is the role? What is the role of PET scan in non-seminoma? And is it where usually using PET scan, seminoma or non-seminoma? What is more?
In non-seminoma.
The PET scan.
Yes, in non-seminoma, because if there is a remaining tumor more than 3 centimeters, not for surveillance, for surgery. If there is avidity in the PET scan, there is uptake.
So the cutoff for you is 3 centimeters.
Yes.
Not 1 centimeter.
Not 1 centimeter, 3.
3 centimeters. Okay.
Yes.
Let us see what is we doing.
Role of PET scan is seminoma.
So, what is that?
PET scan in seminoma. Is it in seminoma?
In seminoma.
Yes.
Yes, PET scan mainly we use it in seminoma, not non-seminoma, PET scan. And here we come to the rule 2. You can see it here. Northern policy in non-seminoma. It is not like seminoma. All patients with non-seminoma, northern policy. We resect everything. And here, and I told you, the 1 centimeter is actually the cutoff. Maybe if it's less than 1 centimeter, you don't need to resect. But if it is 1 centimeter, you will need to resect 1 and above. So repeat CT post-treatment. If residual mass must be resected. And then this, after you set the mass, like this is, we set 3 centimeters, need to be resected. On the pathology, if there is still more than 10% of viable tumor cells, so in this case, we need to give chemotherapy. We need to consolidate with chemotherapy after surgery. If nothing, so no more chemo. So this is rule number 2. Rule number 1 is that markers should be declining and not increasing. And rule 2 is no lump policy in non-seminoma. In seminoma, the things will be different, and we can use PET in seminoma. So the next case is this the 40-year. I don't know the time is okay with you or no. If you can stop me at any time, but it will not take long time. So this is a 40-year man with intermediate risk metastatic and seminoma germ cell tumor treated with 4-bed. So this is advanced state, but it is intermediate risk. Pulmonary metastasis decreased during chemotherapy. Tumor markers normalized. So still we have lesions in the lung. You see him in a follow-up clinic 4 weeks after his last cycle of birth. And notice his pulmonary metastasis have grown, but his tumor markers are still normal. يعني في البداية أعطيناه 4 cycles وحصل له reduction في pulmonary lesions حقته metastasis. His tumor markers normalized. When he came back وعملنا سكان ثانية لقينا إنه there is a growing tumor. There is a metastasis. The lung is growing. The tumor markers are still normal. So here there is 2 questions I need you to answer. Is there a name for this clinical phenomenon? What is the appropriate treatment plan now? الله يا جماعة المشاركة. صابرين في المشاركة. Or Aya. طيب anyone?
This may be this growing teratoma.
Excellent. Okay, what you will do? What is the treatment? So this is a growing teratoma. Okay. And what you will do? What is the treatment? You will follow up, or you will resect, or what you will do? Or you will give treatment, chemo. So you have three options here: either to leave it and follow up the patient, or to resect it, or to give chemotherapy, or to give radiotherapy, whatever. So, any idea?
Follow up.
Follow up. And then, no, actually, growing teratoma should be resected. It should be resected. So, growing teratoma syndrome, growing masses despite normalized marker due to teratoma, treatment is surgery here. It's very important to resect it. But why? Because sometimes you can find something and you need to give treatment. So, viable tumor, or sometimes what will happen to teratoma usually? Might change to, like, the tumor markers are normal, might change to other. This is the problem with teratoma. It can change to other cancer like sarcoma or something like that. But we will not give chemotherapy here. The additional chemotherapy is the wrong answer because the tumor markers are normalized. So this is rule 3. And we come for rule 4. 3 years after finishing PEP ×4. So this patient finished the treatment of advanced melanoma germ cell tumor 3 years ago. And tumor markers rise and new lymphadenopathy is seen. This is after 3 years. The first question, is this a good, bad, or very bad? And what do you do now? Yes. So this is like late relapse. It's rising tumor markers.
late relapse.
Yes, late relapse. Yes, this is 3 years. You finish the treatment 3 years ago. And on follow-up, the patient coming to you, your clinic follow-up, you find that his tumor markers is increasing, and you do CT scan showing there is a lymphadenopathy. Is it good after a long time? This or bad or very bad? And what you will do there?
Yes, if it is late relapse, that means more than 2 years, it is good. Because
Okay. Any other opinion? Yes, by common sense, it's good, but it's not good. What do you do now? What do you need to do? Late relapse syndrome. This is called late relapse syndrome. And if it occurs more than 2 years, will be very chemo resistant. Yes. Yes. The treatment is surgery. But by common sense, I will say this is good. Actually, it is a counter intuitive. So it will be like that. So this is bad. And usually they are chemo resistant. And you will do surgery, and chemotherapy is the last resort for it. So these 4 rules you need to know it. The markers, high and normalized, known policy, especially in non-seminoma, growing teratoma syndrome, need to be resected, and late relapse syndrome is a bad, and treatment also is surgery. Okay. So what is the role of transplant? Peripheral blood stem cell transplant. Actually, most most centers forced to be parents already previously exposed to chemotherapy, originally for advanced disease, using chemotherapy refractory disease, but very poor outcome and in poor prognostic patient. We can go upfront. We can close with poor prognosis. We can go for upfront. People blood stem cell transplant, giving high dose chemotherapy which is autologous stem cell transplant, but we know the toxicity is very high, and it's like 5 to 10% mortality. And this is one of the options, but usually we are doing the transplant for those with after relapse or those refractory disease. Bleomycin toxicity. This is a study done in UK by the Royal Marsden Hospital. More than 800 patients done in 1982 and 1999. They found that 6.8% pulmonary toxicity. There is symptoms and X-ray findings. 1% death of dead patients, and median interval of toxicity like 4.2 months. And as I mentioned here, this is the risk of this is the risk factors. Older age, which is more than 40, advanced state also one of the bleomycin toxicity. If there is renal impairment or poor renal function, and the dose is more than 300 bleomycin. And here on this table, they are putting one risk factor, or 2 risk factors, or 3 risk factors. If combined to separate, we give you the percentage of having this is the bleomycin toxicity. And I will add here also smoking is one of the, if the patient is a smoker, also will put in the risk. We can add it to this for age and advanced state for renal function. Those are bleomycin. This here shows the red toxicity. Oh, this is for cisplatin, toxicity or toxicity, neuropathy, gonadal toxicity, and also induction of leukemia, cytosine, also possibility of leukemia is there, and gonadal toxicity, bleomycin mentioning, plus vascular damage and gonadal toxicity, also sample toxicity, as ifosfamide secondary neoplasia and gonadal toxicity. Regarding secondary leukemia, and this is comparison alkylating agents versus topoisomerase inhibitors. The interval after therapy per years, 5 to 7 years for alkylating agent, 2 to 3 years for topoisomerase. The morphology of the leukemia M1 and M2 for alkylating agent, M4 and 5 for topoisomerase. Alkylating agents commonly causing myelodysplastic syndrome, prephase, topoisomerase is rare, and the cytogenetics 5 and 7 deletion for the 17 balance and translocation. So this will show you secondary leukemias to be very. Gonadal toxicity, 50 to 80% are already infertile prior to therapy. So here, this is sperm banking we discussed. It's very important to counsel, at least to inform the patient that he can do sperm banking and to counsel him about future fertility issue. Cisplatin is also can cause gonadal toxicity, but it depends on the dose. 50% of patients who wish to father children are able to do so after chemo. Sperm banking important selection, very important. Conclusions. Testicular cancer is highly curable. Poor prognosis and relapse disease is subject of most research, doing especially high dose chemotherapy and human stem cell transplant, even giving the upfront. Remember that the D-rules and not those reviews of delay because of counts. This is very important. So, So I decide, actually, I finish now. It depends if you have time. You can go through the questions. We have these scenarios actually, and go through it. If no, we can stop. Okay. So Salah, continue.
السلام عليكم.
عندنا some case scenarios can continue them.
لا في زمن.
Okay, so I will go quickly. So
Yeah.
this is a 32-year-old man diagnosed with a mixed germ cell tumor of the testes. He has 4 centimeter retroperitoneal mass, but no other evidence of metastatic disease. Okay, serum tumor markers are normal. Okay, this 4 centimeter retroperitoneal serum tumor marker. He is started on Germ chemotherapy with a plan to give 3 cycles. Okay, after cycle 2, he complains of back pain, and a repeat CT scan shows that the mass is now 5 centimeters growing. Which of the following would be the most appropriate management plan? Okay, switch the chemotherapy to 4 cycles of TIP, also increasing. Okay, stop the chemotherapy and perform erythroperitoneal lymph node dissection. Complete the 3rd cycle of PEP and perform erythroperitoneal lymph node dissection. Okay. Stop the chemotherapy and perform. So when I said mixed germ cell tumor, this is non-similar. Non-similar. 4 centimeters. From the beginning, the serum tumor markers are normal. What is stage of this? And he started on that. He completed 2 cycles, and then his tumor is growing. So the only follow-up here by his tumor, because the serum tumor markers are normal. So do we need to switch to give another 4 cycles of deep chemotherapy, or to do erythroperitoneal lymph node dissection, or complete their cycle? Any idea? Even by guessing, even if you want to guess. Allah Inas.
Retro. Yes. Nerve sparing retroperitoneal lymph node dissection.
Erythroperitoneal, okay. So stop chemotherapy. So we'll stop
Yes.
chemotherapy and then yes. This is a right answer. So what is the learning point here? It is important to recognize growing teratoma syndrome. That is what we mentioned. The treatment of growing teratoma is resection. Usually we said why growing teratoma and not relapsing? Because the tumor markers are normal. Masses that grow during chemotherapy are open teratomas, which are chemotherapy resistant and need to be resected. So the correct answer is B. Question 2. 25-year-old man presented with a mixed germ cell tumor of the right testis. He has lymph node and liver metastasis, an alpha fetoprotein of 900, an HCG of 800, and a normal LDH. What is the most appropriate treatment for him? So, generally, you need to stage him like he's a lymph node and liver metastasis. So, when he has a liver metastasis and non-similar, what is this stage? He has stage 3. This is advanced. What you need to put him in what is good or intermediate or poor risk. So definitely this is not a poor risk. Am I right? Maybe I'm wrong. So what is the treatment? 4 cycles of BIP, 4 of PEP, 4 of EP, 4 of TIP.
4 cycle of PEP.
Okay. Not 4 of EP. Let us see. I'm not sure. So the answer is B. You are right. 4 cycles. Why not VIP? VIP usually we are not giving it if we can give them. unless we are afraid of toxicity, bleomycin toxicity. EP will equal 3 cycles here of PEP. And TIP usually we are not giving it up front, usually we are giving it like after relapse. So metastasis to organ other than the lung is one of the poor risk criteria. This patient just has so he had a poor risk from his metastasis, sorry for that. So regardless of the tumor markers here, because he has liver metastasis, standard treatment is 4 cycles of PEP. VIP should be only substituted for PEP when there is a contraindication to bleomycin or when the patient has a primary mediastinal non-seminoma. Question 3, the patient is question 2, the same patient, which is a poor risk non-seminoma with liver metastasis, coming to start his second cycle of chemotherapy. After you start the oral. Well, now, show the platelets counts of 70,000. Well, creatinine 1 to 1.8. And the most appropriate response would be which of the following? Post chemotherapy and have patient return in 1 week for repeat labs. Reduce the doses of etoposide and cisplatin by 20%. Substitute carboplatin for cisplatin and renal function better than continue the chemotherapy at a full dose. This is easy. صح? Is it easy? What to do? Anyway, I need you to answer. نهائي. هلا عم الله. ما شارك. Anyone? This is the same patient. أخذ 2 cycles. Therefore, no, أخذ 1 cycle only.
Substitute the for cisplatin.
Substitute the carbo.
Yes, rule of don't delay or don't reduce. So
What you will do? يعني what is your choice here?
substitute.
هل you will delay the treatment?
No, anyhow, I will not delay or hold the treatment. I will not reduce the dose by 20%.
So what is the choice?
Substitute.
What is I mentioned it? This is very important. I mentioned it, and I make a stress on that. And do not reduce the dose. Do not delay the dose. And carboplatin is not equal to cisplatin.
Not equal.
أيوة. Do not substitute carboplatin with cisplatin.
So I will
Also.
continue full dose.
Yes, full dose. Yes. Correct answer B. This patient has a poor risk dissipated TM cell tumor. This is a curable plasma. The clinical trial that established PEP4 times 4 did not host chemotherapy or reduce dose for low blood cell counts for moderate renal impairment. Because the renal impairment is slightly increased. Carboplatin is less effective than cisplatin. Caution is needed with regard to giving bleomycin to patients with renal insufficiency. إذا أنتم تكونوا خايفين من أكثر شيء. خايفة من إنك تعطيه bleomycin مع renal impairment. لكن هذا is so hypercontin. The same without dose reduction. Even the platelets is low. Question 4, the same patient from question 2 and 3, the same patient. Return at the completion of chemotherapy. Three-stage CT scan shows that all metastases have declined in size, but still has a 2 centimeter mass in his liver. And 2.5 and a 2.5 by 2.5 retrogradial lymph nodes, serum tumor markers are normal. What is the most appropriate system? يعني حتى لو ما شفتوا الأيوة أحط جوابها واحد نفس البيشنت اللي هو كان بور ريسك يصير منه دم ستيج 3 أخذ 4 cycle of chemotherapy. A CT scan showed that there's a decline to the response. في الليبر 2 centimeter وفي الريتروكابيتولين 2.5 by 2.5. What we will do, a serum tumor markers is very important are normal. هل نعيد الأشعة repeat CT scan in 2 to 3 months? Obtain a PET scan and dissect the residual mass if they are FDG elevate, retroperitoneal lymph node dissection and dissection of the liver metastasis, 2 more cycles of chemotherapy followed by this. 2 more cycles of followed by this. And this is what أنا بسهل لك. What is the role? This is, I put 4 roles in the beginning. This is one of them. الله يذكرها. What to do? هل ايه نعيد السكان بعد شهرين ل3 شهور ولا نعمل بيت we discussed it already ولا نعمل سي او بايسكشن تقريبا ولا ندي كيموثيرابي زياده وبعدين نعمل سكان ثاني. دائما لما يكون عندك التمر ما ايوه تفضلي.
ده ريبيت الاسكان.
repeat in 2-3 months.
Two cycles of chemotherapy, then repeat the scan.
So the answer is 2 more cycles.
No need to give more cycles because the tumor marker are normal, return to normal.
طيب انت قلتي ايه يعني repeat السكان 2 to 3 months.
Yes.
طيب انت مع التو سايكلز وانت مع without يعني both of you want to repeat the scans but one of you said 2 cycles and the other said no need to give chemo. طيب وليه ما نعيدها ما نعمل بيت سكان؟ طبعا نحن قلنا this is not seminoma وقلنا البيت it will not help.
It will not help unless CT scan finding is inconclusive. Then I will go for bed.
طيب انت الان السي تي عندك فايندنج عندك ليفر احنا قلنا الرول اوف نوما سيجنال سيمينوما نورمال هذا قانون يعني انت 2 to 3 months هذا ديلي البيشنت هيجيب انكريزنج you need to reset it. This is very important يا بنت. and I mentioned in the presentation we need to reset it. اي شيء اكثر من 1 سنتيمتر we need to reset it. عنده 2 سنتيمتر عنده 2 سنتيمتر ماس في الليفر وعنده 2.5 per retroperitoneal. We need to resect all. Urology يعمل ريسكشن يعمل retroperitoneal dissection ويجيب hepatobiliary to resect the liver lesion or whatever general said to resect. We need to remove everything. And after we remove, يعني هنا serum tumor markers is normal. After we remove it, if there is a viable tumor adhesion more than 10%, we need to give 2 cycles of chemotherapy after that. Well, this is the correct answer is C, which is the resection of the liver mass. Whenever technically PCT patient with metastatic non-seminoma should have all residual disease receptive as the completion of chemotherapy if the theory of tumor markers are normal. The only role for PET scan in metastatic germ cell tumor is to assess residual masses following chemotherapy in men with pure seminomas. PET scan have no role in the management of non-seminoma or mixed germ cell tumor. ما أحفظوا دي ما أعرفوا. طيب PET scan مع السيمينوما PET مع السيمينوما. We need to resect. This is our own line. Question 5. Or the program is set to the left testis mass and ultrasound confirm presence of a mass. Serum tumor markers show normal LDH, beta HCG is 50, and alpha fetoprotein of 70. The man undergo left inguinal orchiectomy. Pathology report of 4 centimeter pure seminoma with invasion of the rete testis, but no vascular invasion or invasion of the tunica vaginalis. No metastasis are seen on chest X-ray or CT of the abdomen and pelvis. Serum alpha fetoprotein and beta HCG are normal following orchiectomy. Which of the following would be the most appropriate option for this patient? Surveillance, radiation therapy, using para-aortic field, radiation therapy using a total field, for 1 cycle of single agent carbohydrate. 40 years. Yeah.
هو يفيدونا الفايروس تيتر
ما سامعك الصوت شوية.
هو ستيج 1 سيمينوما with high risk feature. So
Stage
I
one
will
seminoma.
go for adjuvant single agent carbo.
أيوة.
ما في inferiority بين الريديوسيرابي والكاربو single agent.
بس اللي تفاصيل الانفيجن ما في انفيجن يعني ما عنده with invasion of the عنده invasion of the rete testis. اوكي. يلا خليه هاي ريسك.
Yes, high risk.
هاي ريسك. طيب what else we will do؟ بس هو ده سيمينوما او نون سيمينوما. انا ما بعرف يعني الالفا فيتو بروتين هاي ليه الالفا فيتو بروتين هاي؟ انا قلت في السيمينوما يكونوا نورمال التيومر ماركرز كلها يعني اذا انت عندك انا بالنسبه لي توصيلها للنون سيمينوما in spite of الباثولوجي ريزامبل.
هو السيمينوما
ممكن البيتا اس جي
ايوه في بروتين بيتعامل مع عمليه النون سيمينوما.
النون سيمينوما صح؟ That is the answer. And I am not sure. لأنه الألفا فيتو بروتين should not be high at all. Should not be abnormal in seminoma. حتى الباثولوجي يعني وطلع بيور سيمينوما في الباثولوجي. السؤال هذا هو stage 1 سيمينوما or non سيمينوما. هذا السؤال. Correct is A, which is surveillance. It is correct. Do surveillance. This is one of the options. لكن seminoma do not produce us for 50%. يعني انت ده يعني حتى الباثولوجي عندك الباثولوجي seminoma مكتوب لكن الفيتو بروتين هاي there is element. So this patient's tumor must have an element of a different type of nerve cell tumor, such as Yorkshire tumor or embryonal carcinoma. Therefore, it must be treated as clinical stage 1 non-seminoma. Or the treatment option, even surveillance, is the only one that is appropriate for a non-seminoma. This patient would be at a relatively low risk of relapse given the absence of lymphovascular infection. فدايما بيعتبروا من السيمينوما. دايما بيتذكروا التيومر معهم. مرات بتكون مايند انكريزنج البيتا اس جي بالسيمينوما. يعني تكون له مثلا يكون يقول لك بيتا اس جي اوف 10 مثلا كده. يعني مايند لكن جاما سبيكينج الفا فيتو بروتين هذا نون سيمينوما. وتابع الفا فيتو بروتين هاي نون سيمينوما. Okay, question 6. 35-year-old man present with the right depth enlargement and indentation. Ultrasound show a 3 centimeter heterogeneous mass. Preoperative alpha protein 65 and beta HCG 800. He undergoes a right inguinal arteriectomy and pathology reports 50% embryonal carcinoma, 30% yolk sac tumor, and 20% teratoma. CT scan of the chest abdominal pelvis show a 10 centimeter retroperitoneal mass and over a dozens of pulmonary nodules, the largest of which is 3 centimeter. There is no evidence of metastatic disease elsewhere. يعني عنده retroperitoneal mass. والتيومر ماركس حقته ممكن أقول إيش؟ S1 صح؟ وعمل البريكتومي والشوت ميكس بس عنده بيجر retroperitoneal mass ده بيخليه ستيج كامل. Which of the following would be the most appropriate treatment for this patient? 3 cycles of PEP, 4 cycles of PEP, 3 cycles of VIP, 4 cycles of PEP. Which is 3 cycles of VIP leading out of the mind? 4 cycles of VIP going up and giving it at the some point. 435 minutes. طيب ايش هذا كم ستيج هذا؟
هو 3B.
ليه قلت 3؟ البيشنت ده ما عنده غير عنده ريتروبيريتونيال ليف نودز صح؟ ريتروبيريتونيال ما عنده بالمونري اوكي بالمونري اوكي طيب 3 بي اوكي and what you will treat it orbit. The answer is the patient has no adverse prognosis. He is in a good risk category of disseminated disease. Also, he has pulmonary metastasis. This is not an indication of VIP, nor has VIP been studied in good risk patient. If one made a clinical decision not to give bleomycin due to the extensive pulmonary disease, or bit of silence would be the appropriate regimen to use in a patient in non-resection of residual pulmonary disease anticipated using EP4 multiplication and multiplication so it is only 3 sides. Okay. لأنه هو good risk. مرات أنت يعني الواحد ما يتدخل التيومر سايز لأنه البلمونري ميتاستاسيس he will not put him in the poor risk. Pulmonary metastasis unless he has other metastasis like liver ولا brain أو يكون عنده التيومر ماركرز حقته very high which is like F3 عشان تحطيه في البور ريسك. لكن عنده S1 هو وعنده pulmonary metastasis بغض النظر عن الكمية بتاعت الpulmonary metastasis the number بغض النظر عن السايز of the retroperitoneal. فهو stage 3 لكن good risk category. The right is 3 cycles of it. Okay. Question 7, I think this is the last one. 28-year-old man, left testis mass, malignant ultrasound, preoperative alpha-fetoprotein is 2,500, HCG 1,800. 1 week after left inguinal abdominectomy, the alpha-fetoprotein drops to 1,200. And the beta CE to 400. CT scan shows a 4 centimeter retroperitoneal mass, 4 centimeter mass. 1 week later, on day 1 of chemotherapy, alpha-fetoprotein 800, beta CE 100, and LDH 1.5. The most appropriate chemotherapy for him would be 2 cycles of PEP, 3 cycles of PEP, 3 cycles of BP, 4 cycles of PEP. يعني بعد السيرجري التيومر ماركرز نقصت 1 week وبعد ثاني اسبوع ثاني نقصت لكن ستيل هاي. And to me 2 weeks are not enough for alpha-fetoprotein. صح؟ لو فرضنا البيتا اس سي جي normalized, in this case I will wait another 1 or 2 weeks. Correct me if I am wrong. I will wait another 2 weeks for the alpha-fetoprotein. لكن once after 2 weeks, لأنه البيتا اس سي جي half life هنا 1 to 2 or 3 days. So in 2 weeks should be normalized. يعني حتى الالفا-فيتوبروتين بعد 4 أسابيع إذا نقص this is maybe still high. عشان كده نحن بنختبر هنا التيومر ماركر. We will stage him at this stage. طيب what we will do for him? عنده S1 disease.
Now you will give 3 cycles, BIP.
أيوه. 3 cycle. Okay. And take the 3 cycle BIP. ليه؟ هو stage كم هو؟ هو stage 1 or 2؟ أول شيء ده stage 2 صح؟ stage 2.
Stage 2.
ايوه لانه عنده ريتروبيريتونيال ليمف يعني once انه في ريتروبيريتونيال ليمف خلاص this is stage 2 وما عنده distant disease خلاص this is stage 2. لكن stage 2 كم؟ A ولا B؟ عنده التيومر ماركرز is high. لانه احنا usually we are staging طبعا انتوا you know this انه staging after السيرجري وafter السيرجري not immediately 1 week is not enough. جابوا another 2 weeks 2 weeks for beta HCG لكن 2 weeks not enough for alpha fetoprotein مرات for 5 weeks وبعد اسبوعين ال HCG not normalized يبقى في S1 هنا صح؟ يعني في الستيجنج المفروض يكون في هاي تيومر مارك فبقى الستيج كم ده 2 شنو؟ 2 2B 2B. طيب what is the treatment?
3 cycle
3 cycle of PEP ولا
4
4
cycles.
cycles 4 cycles of PEP not 3 cycles.
3 cycle BEP or 4 cycle ED.
B what is B? 3 cycles of PEP not 4 cycles. This is stage 2B.
Yes.
Am I
4
right?
cycle ED.
أيوه
BEP
الستيجنج كيف؟
BEP 3 cycle ED 4 cycle.
إذا كان ده قصدك EP 4 cycles ايوه يعني يمكن تدي EP 4 cycle ولا تدي بيب 3 cycle لانه we stage is right انه stage 3 to be favorable risk disseminated his serum tumor markers were highly elevated prior to alpha-fetoprotein and are declining after alpha-fetoprotein. Although his alpha-fetoprotein and HCT were in the intermediate risk range prior to alpha-fetoprotein and alpha-fetoprotein remained in that range 1 week after alpha-fetoprotein. It is the serum tumor markers level on day 1 of chemotherapy that determines the patient risk category. On day 1 chemotherapy, all of his tumor markers level were in the favorable, which is S1 range. Therefore, in the absence of metastasis to organ other than lung, he is a favorable risk patient. هو favorable risk. بس هي مهمة جدا التيومر ماركرز after surgery. حاجة اسمها day 1 أنا I disagree with this day 1 of chemotherapy. Usually we need to give طبعا أنت بتاخذ interval after surgery يعني لكن وأنت you need to start as soon as possible. لكن زي ما قلنا نشوف موضوع الهاف لاين. Thank you and good luck for your exam.
Thank you so much دكتور أمين ختامه مسك وصراحة المحاضرة أفتكر إنها من المحاضرات على قلة التفاعل لكن أفتكر إن الناس تفاعلوا فيها وأعتقد هذا يدل على أن الناس يعني قيمة المحاضرة.
هو طبعا التستيكولار كانسر يعني ممكن يكون في الاكزام ما بيجي يوم فيه بالكو يعني طبعا ما زي الألغص يعني الجينيتورينري جنرال يعني برضه ما يركزوا على البيج يعني انا ما ادفايز انه تكونسنتريت على البيج كانسرز والكومن كانسرز لانه الازمه دائما بتكون مور في البريست كانسر وفي الجي اي كانسر سبيشال كولوريكتال كانسرز في الجيو برضه عندهم الكدني والبروستيت نمبر 1 نقول وبعد ذلك على حسب طبعا يعني هذا فهي طبعا they might come in questions and they need to know it in their practice كذا بس my advice انت concentrate على البيج كانسرز وربنا يوفقهم.
والله أمين يعني شغلهم الإكزام هناك بيحبوا الأسئلة بتاعت التستفرير دي لا يخلو منها.
ايوه اوكي
يختلف من حتة لحتة لكن أتوقع إنه يكون في شوية أسئلة. طيب في أسئلة له لدكتور أمين من أي واحد من الحضور خلف الكواليس؟
هم اللي حضروا كم كم 7 ولا كم؟
والله إحنا ممكن إحنا حافظنا على 13 لحد النهاية ممكن يكون ب 11 في ناس مع الشبكة بتطلع.
ايوه صح والله الشبكة
بيطلعوا ثاني. أصلا عندي يعني وان كومنت وفي عندي سيناريو عايز احكي عنه يعني two of my patient one of my patient هو كان around 30 years عنده 3 kids ودياجنوز بوست اوركيوكتومي بكلاسيك ليمفوما كلاسيك سيمينوما والجراح لما جابه وعرض في التيومر بورد يعني بيكون في قال عنده ريتروبروتينيال ليمف نود 2.5 براورتيك ليمف نود. ونحن في التيومر بورد we stage him as stage 2. التيومر ماركر طبعا نورمال، الفيتوبروتين بتبقى سيمينوما. we advise for retroperitoneal dissection for him. ف الجراح كان ريلكتنت في انه يعمل، يعني الجراح انت عارف لما يجي يعمل كونسل للمريض، المريض بيخاف، يقول في سايد افكت وزي ما ينجل الباول وكمان ينجل
يا صدق دكتور صلاح ده انت قلت سيمينوما، هو سيمينوما ولا نون سيمينوما؟ لان اذا سيمينوما انا
لا
انا
نانسي مينوما
نون
نانسي
سيمينوما.
مينوما
ايوه
ميكس
لانه اذا
ميكس
سيمينوما، اذا سيمينوما هنا في
ميلادو سيرابي. اي لا كان
ايوه
ميكس جيرم سيومر،
ميكس.
ميكس جيرم
اوكي
سيرابي.
اوكي
سوري.
اوكي
بعدين لما جينا نعمل الجراحة، المهم كان الموضوع يعني بالنسبة له he choose the other choice اللي هو كيموثيرابي. ف عملنا كونسلنج المريض، وعملنا رسلناه للفور سبير بانكي، واخذ الكيموثيرابي كونسنت، فرسلناه وعشان نعمل دي 1 برضه يعني تيمر ماركرز. وانا عدت السي تي، لما عدت السي تي طلع نو ليمف نود. ف نو ليمف نود
بعد
اتو
كم؟ بعد 1 سايكل؟
نو بيفور ستارتنج. ف ايوه، فبقى الان هو يعني بالنسبه لي يعني كده بقى ستيج 1 ونو ريسك، ونو ريسك فيتشر اتو. ف... فانا بالنسبه لي المريض يعني خرج من انه كان حياخد كيموثيرابي with all complication of chemotherapy, uh, and now he's stage 1 with no feature, with no high risk feature. ف
what is the reason of disappearance of the lymph nodes?
ده والله ما هو هي دي الاسئله. هل كانت رياكتيف؟ هو بيقول الرئيس بيقول it was a react
السايز كان
كان 2.5.
ايوه طيب كانت رياكتيف ورجعت للنور. اوكي
يعني at that time لما ناقشنا في التيومر بورد، يعني احنا this is pathological lymph node for resection for retroperitoneal lymph node dissection. This is the tumor board. Strange enough, before starting chemotherapy and after taking consent, spare banking, the CT both up came as reactive lymph node.
ايوه
ف...
انا سوري صراحه انا منشن كده البرسنتج بتاعتها اي منشن ايه يعني انت عارف مرات انت افتر باثولوجي يعني حتى لو هو اجريد انه السيل تشيك الى ابفرونت يعني السيل له sometimes you can down stage from 2A ل stage 1 اذا طلع عندك نيجاتيف. يعني هو that is right that is accepted يعني that is expected يعني لكن ممكن انه حتى لو عمل السيرجري you can down the stage pathologically بيبقى بعد ذلك انك يستنشم بدل 2 بقيت 1. ايوه اوكي انا قطعتك معلش بس يعني.
تمام اوكي. يعني انا what I want to my message انه الCT both up I think will be يعني a
Yes.
good reason for studying. يعني don't rely on pre-op CT. This is one thing. The other case جاءنا برضو بنانسي ميلوماتس جيم سيل تيومر، وكل الريسك كان ستيج 1 بالسي تي باي ماركرز everything، لكن كانت عنده embryonal component.
ايوه
All the tissue, يعني it comes like this. It is embryonal component 100%. No other.
Okay.
يعني which is rare, but it is stage 1. It's stage 1. No lymphovascular invasion, no spermatic cord invasion, even not reach scrotum. ما في يعني there is no risk factor. Based on the guidelines, stage 1, non-seminomatous, no risk factor. يعني just we can choose as surveillance and is one of the option, or it is the best option now, right?
Definitely. Yes.
Right. But what I want to raise this point, when I read in depth, embryonal type of mixed germ tumor,
is a high risk.
it may be considered. يعني it is not strong like vascular invasion. فهتلقى هنا two schools, whether to give or not to give. So in the future, they may add it clearly. Anyhow, my patient now under follow-up, I do for him 2 session of follow-up, is still free of disease. بس يعني هي difficult بي حتى الآن لأنه I don't know which embryonal type considered as يعني it may be add to the risk factor sooner or not.
والله شوف الامبريون طبعا اذا كان بيور امبريون this is the highest. اذا كان بيور امبريون it is the highest. وحتى البرسنتج اذا مرات ميكس كيرتي سنتيوم جيت البرسنتج حتى الامبريون الهاي شويه برضه يو مايت كونسيدر حتى الامبريون مايت ستاف اكيد ممكن تطلع عليه طبعا كثير من يعني this disease is happening in this age group. ودائما age group يعني 20s or 30s عندهم problem with the follow-up, the compliance. بيحصل كثير جدا ما بيتابعوا. This is sometimes هنا we consider it as an indication of chemotherapy, which is very, very طبعا شكله strange شوية. يعني البيشنت إذا ما كتب يحصل تدريب كيموثيرابي. إذا أنت حسيت البيشنت ده نوعية البيشنت ما حيتابع معاه وأنت بتقول له متابعة بعدك ما بيجي. إذا أنت حسيت وأنت البيشنت معاه give him this مثلا 2 cycles whatever 1 or 2 cycles 1 cycle or 2 cycles. It's better here بيكون التريتمنت أنا بتكلم جنرال طبعا هنا سيمينوما أو نون سيمينوما for like even carboplatin. إذا حسيت بأنه البيشنت مع السيرفيلنس ما حيكون good I will give him the treatment. This is one of the indications. وإذا برضه نون سيمينوما I will give him 1 or 2 cycle of PEP عشان عارف إنه البيشنت ده he will not follow. لأنه الفولو up is very important. فإذا كان poor compliance this is an indication of giving treatment.
اوكي في سؤال كده role of scrotal irradiation. I think يعني
irradiation for what؟
scrotal.
يعني بعد السيرجري ولا شنو؟
والله يمكن السؤال هو مقصود به اذا يتعمل ترانس سكروتال اوركوكتومي. كده مقصود يا ايناس؟ يس. كأنها تقصد انه اذا this is a wrong approach to do transscrotal. Is there any indication of scrotal irradiation if the urologist did this procedure?
والله unless there is disease طبعا هو يعني مع urologist if he do it so the scrotum this is inappropriate صراحه. لكن if he did it انا ما بعمل scrotal irradiation blind كده لانه برضه حتى السيستميك تريتمنت will help. ما في انديكيشن هنا لانه انا اعطي irradiation يعني. وممكن يكون ما في شيء ممكن يكون ما في ديزيز برضه يعني depends. لكن اذا حصل ريكارنت ولا كده we will use a systemic therapy يعني to treat the patient as a whole.
In my opinion, scrotal surgery, as you said, it will disrupt the lymph node, the lymphatics. The other difficulty in doing sclerotal irradiation, it's very difficult to shield the other tests to be
Yes,
away
طبعا.
from, and it is very sensitive طبعا for radiation. So I think sclerotal irradiation is not a good approach in treating a patient underwent transsclerotal or curtain.
يعني هنا بنكون we commit two mistakes here. Number one is doing the surgery scrotal approach or giving irradiation to the scrotum. Oh, this is enough for me. We don't do that.
أنا يعني also I want to draw the attention of the attendee. يعني if you go for definition of S1, S2, and S3, you find it by figure less than 1,000, less than 5,000 for beta HCG. I think Dr. Amin here, he said that يعني for sometimes the tumor marker will not be, there is false positive. So he came to the cut point 3 multiplied by upper level of normal. Some text مرات يعني بيختلفوا. هل يا أمين أحسن يكونوا to go for this cut point ولا to follow the guideline?
والله صح هو شوف there is no other يعني high LDH أيام ما يعني ما في other reasons. يعني البمبر هو طبعا not specific وكذا لكن go with the guideline يعني go with the 1.5. This is the right thing. Go with it. لكن إذا في other reason and what will increase it LDH يعني إذا ما هو عشان يبقى other high tumor markers يكون ال other tumor markers are not high. لكن generally it's better to go with what is written. 1.5.
Like
1.5.
also, I want to draw the attention when they speak and when they write S1, they consider alpha fetoprotein, beta HCG, and LDH. So if alpha fetoprotein and beta HCG are normal and the LDH is high, so systemic disease, don't treat the patient only as by evidence of elevation of LDH.
Yes.
Am I right? Am I right,
Yes.
attorney?
Yes, you're right.
So this is another point should be considered, especially in stage 1S. Yani, patient should not be treated with chemotherapy for systemic disease if the only evidence of systemic disease is elevation of LDH.
Yes, I totally agree with you.
في سؤال ثاني يا الصوت؟ كده اقول لك الصوت بيتراوح بين
Yes. Stage 2.
Doctor, for radiotherapy and chemotherapy, options for لكن ممكن تكون ايه ممكن بالنسبه للراديوثيرابي على الاثنين في سرفايفل ادفانتج مع الراديوثيرابي.
قصدك على الراديوثيرابي ولا الكيمو في ستيج 2 سيمينال؟
في ستيج 2 ايه لكن ما 2 بي.
ستيج 2 ايه
ايوه ممكن بالنسبه للراديوثيرابي الكيمو في سرفايفل ادفانتج الراديوثيرابي والكيمو ولا؟
والله شوفي بالنسبه للستيج 2 A the standard is radiotherapy. The standard is radiotherapy. Stage 2 C, you are speaking about stage 2 A seminoma. The standard of care is radiotherapy. For those يعني ما هم شوف stage 2 A يكون less than 2 سنتيمتر. والبي بيكون more than 2 سنتيمتر. the treatment, the radiotherapy is the standard of care here. But you alternatively you can give chemotherapy if you want to avoid it. إذا كان في contraindication للراديوثيرابي، طبعا مرة ممكن يكون في contraindication للراديوثيرابي. في الحالة دي أحسن to give 3 cycles of PEP or 4 cycles of EP. 3 cycles of PEP or 4 cycles of EP. إذا كان stage 2. لكن إذا جاك سؤال بالام سي كيو إذا ستاندرد راديوثيرابي لكن مرات يعني difficulties وكذا discussion with tumor boards وكذا you can change it with the team giving them 3 or EP4.
أنا also I want to add to this point. يعني إحنا قلنا stage 2 pure seminoma، يعني بيتكلم عن 3 options على الترتيب. الفيرست زي ما قالوا الترامين هو الراديوثيرابي برا اورتيك ان ابسيلاترال الياك ليمف نود اللي هي يسموها دوغلج راديوثيرابي. اللي هي بعده على طول اللي هي الكيموثيرابي 3 بيب اور 4 اي بي. لكن برضه هم حاطين one of the option اللي هي الريتروبروتينيال lymph node dissection nerve sparing as a third option. بس يعني which is prefer is radiotherapy coming chemotherapy بعدين radiotherapy. So الجراحة هنا في stage 2 كبيور سيمينوما تورامين محطوطة كده يمكن على استحياء as one of the options.
والله should not be يعني سيمينوما ريسكشن كل تيست بس للبرايمري ديزيز، لأن أنت الوقت بتاعك ما you don't know exactly. لكن السيمينوما in general يعني it's better to لأن كيمو sensitive وراديو sensitive. السيرجري is not good يعني.
صحيح زي الليمفوما ما في داعي تعرض المريض لكيموثيرابي، لكنه يعني إذا بس أنا قصدي for academic purposes إذا هم يعني they have to يعني it is not wrong لكن it is not the best right.
ايوه احنا ويميشن البيت سكان بتنفعنا كثير في السيمينوما يعني. السيمينوما is not that ugly.
تمام. سؤال ثاني نشوف الشات بوكس ما في حاجة ثاني. احنا في نهاية احنا طبعا يعني عملنا كورس حوالي 6 شهور، بدينا في ماي انتهينا الآن قبل الامتحانات، ندي الناس فرصة لأنها تذاكر وتمتحن ممتحنين. وطبعا هنا احنا كل الناس موجودة هنا دكتور أمين يعني في R1 و R2 و R3 و R4 يعني كلهم بيدرسوا مع بعضين. hopefully from the next year إن شاء الله we start a new journey. أنا شاكر جدا دكتور أمين للشباب دي لأنك تديهم كده دافع معنوي، هم ممتحنين في زمان الحرب بيدافعوا عننا وأشياءنا ونفتكرهم هم يعني on the field بيقدموا الكثير لمرضانا ولنفسهم، ويعني علما يعني بيتدربوا في ظل الظروف الصعبة دي. أتمنى لهم التوفيق. خليك تكلوز السيشن دكتور أمين وإلى نلتقي.
والله يا أخي نسأل الله لهم التوفيق والسداد إن شاء الله، وندعو لهم بالنجاح في الظروف الصعبة خاصة عند السودان. إن شاء الله ربنا يوفقهم ونحن جاهزين لكم في أي شيء على قد ما نقدر مساعدات. ربنا يوفقكم إن شاء الله، وإن شاء الله نسمع نسمع عندكم كلكم ناجحين إن شاء الله بإذن الله. وفي أمان الله.
يا في رعاية الله.